My name is Lindsay Garcia. I'm the executive director of the 22Q Family Foundation. We're very excited to be having this discussion, especially during Autism Awareness Month. Obviously, many of our community has, dual diagnoses of 22Q and autism. Some just have 22Q. And so we thought it'd be important to bring on some presenters to talk about what that means, what that looks like, how that affects long-term care. So today, joining us, we're very excited to be having Donna Cutler-Landsman, who all of you are familiar with. She works at our foundation. She's an educational expert. She's written books about educating children with VCFS, velocardiofacial syndrome. She's an educator with over 35 years of experience and has worked as both an advisor to gifted and talented students, as well as an advocate for children with learning challenges. And she also sits as an educational consultant for the University of Wisconsin. So she'll be starting off our talk, and then following her will be Dr. Kevin Antshel, which I'll just introduce him now. So he is a professor of psychology and director of the clinical psychology doctoral program at Syracuse University. He has nearly 20 years of clinical and research experience in the 22Q field and has published extensively on the topic. He's a licensed psychologist and board certified in clinical child and adolescent psychology. We're super excited to have both of you here and have this discussion. So if you are on the live Zoom, please feel free, if you have any comments or questions, just to put them in the comment box, and then we'll have time at the end. Without further ado, I'm going to let Donna go ahead and take over. Let me just give her access. There she is.
Hi, everybody. Hello. I am super excited to be here today with Dr. Antshel and Lindsay and our 22Q family community out there in cyberspace. In my work through the foundation and also privately, I have run across a lot of issues with adults with 22Q securing long-term care. And I felt that this was really an important webinar to get out into the community. And so I'm very excited to share some of the information that we have to try to help you navigate this kind of precarious way to get services. So I would like to share my screen with you and go through a bit of a PowerPoint here. All right, so what this webinar really is about, this is about actually securing these services. So let's go to the next slide and talk a little bit about what long-term services in the adult world can look like. So here's the kinds of support that's available to families that have an adult child with special needs. First of all, there's Social Security. We've done webinars on Social Security. Most young adults with 22Q would start off with SSI, and then after you have some work experience, you might be able to secure what's called SSDI. These are two different programs. We've done other webinars on those. If you have questions, you can certainly contact us, but that's money only. So that's monthly money that's sent to you, and basically you can spend that money on your needs. Then there are state benefits, which might look like food vouchers, childcare, depending on your income. Those are state programs that also are really based on income level. And for adults that are on SSI, you're limited to the income. I think it's $1,100 a month. So many adults would qualify also for state benefits in food and childcare. There's also vocational assistance, and this can start paving that road in high school. About age 16, you can get help from the Department of Vocational Rehab. They will help you with things like job searching. They can put a job coach on the site to help you with learning a new job skill, making the work accessible, training and tutoring. Some states will pay for your books for a training program. They might pay for your tuition. They may pay for tutoring for coursework. So that's all vocational assistance. They also can do a job evaluation, which is very helpful, where they ask you to do tasks, your child to do tasks, and you can figure out a job that they may be suited for. So I would strongly recommend that you look into vocational assistance. But today's talk really is the long-term care piece. And this is through the State Department of Developmental Disabilities. And this is day-to-day assistance with a wide variety of tasks. So the next slide. So these are things that your child may need as an adult. So some of the things that adults with 22q seem to need some support with are as follows. So budgeting and money management. Some of them need help with emotional support, just understanding the world around them and social relationships. Planning and executing more complex tasks. If they need to secure an apartment, for example, the steps to go through to actually go and rent an apartment. Understanding complicated situations or directions. If a lot is coming at them at one time, it gets complicated. They have trouble really piecing that apart and understanding what's happening. Many of them will shut down and just really not know what to do. Legal documents, if they're given a document to sign, understanding what they're signing. Recognizing when other people are maybe manipulating them or being abusive or trying to sell them something that they really don't need. Advocating for themselves in any type of a situation where they may get into trouble or not quite understand what to do. Explaining something in detail, either in a doctor's office or to a clerk or to somebody on Amazon, what has happened if their bill is too high or something wasn't done correctly, if they registered for something that they didn't think they registered for and now they're being charged a monthly charge for it. Applying for and keeping a job. And then some of them also need help getting around independently, especially if they don't drive and navigating their environment is hard. So those are just examples of the kinds of things that adults with this syndrome typically need assistance with. So what does it cost to provide this if parents are not there to kind of help or another family member? If you turn to an agency like a long-term care agency to support your young adult with these kinds of tasks, it runs anywhere from $30 to $60 an hour. The adults that are receiving long-term care in the community that have secured services have budgets that probably began at $25,000 a year and go beyond that at higher rates depending on the level of need. And over several years, you can imagine how much this can cost a family. And in 10 years, you can extrapolate that out $250,000 to get the amount of care that the adults really with this syndrome typically need. So what we're talking about today is being able to secure that as an adult with disabilities so that instead of yourselves paying $25,000 plus a year, that this cost is covered by your individual state. So how do you qualify? Well, every state has their own eligibility criteria for adults that are 18 years old or older. Most states have these categories: an intellectual disability, autism spectrum disorder, and some states have a third category called developmental delay or similar disability. So we're going to go through these three different areas and talk a little bit about how 22q kind of fits into these. So in order to qualify for an intellectual disability, this is done through IQ scores, and it's done through tests like the WISC-5 or other similar cognitive assessments that are done by a certified neuropsychologist. School districts can also do these tests, but you have to have a psychologist. You have to go to the office and have it done in a research-based, not a research-based, but in a way that is with fidelity. So it has to be in an office through a certified licensed psychologist. So a full scale IQ of less than 70 or 70 or below. There's some play now with this. Some adults with an IQ of 75 or below are being qualified for some of these adult programs. You also, though, need to have, beyond that score on the test, you have to have a deficient adaptive skills. And adaptive skills are your activities of daily living skills, the ability to manage oneself in the environment on the tasks that I just mentioned in the previous screen. There are instruments that can be used to test this. One of them is called the Vineland, which is very commonly used. And often school districts will have these tests and administer them. Again, these can be done in a psychologist's office. Substantial issues in addition with things like communication, attention, initiation of tasks, and oftentimes young adults with 22q do have adaptive issues that they can score in the qualifying area, and they have substantial issues with communication, attention, and initiation. Cognitive score, though, is one that is kind of a question mark. Early on in life, about 70% of children with 22q have scores that are higher than that. However, this does change over time. And some of the research that has come out has shown a drop in these IQ scores over a child's, the longitudinal time that they're measured from early elementary to adult exiting of high school. So when children exit at high school level, a lot of them are hovering around this 70 cutoff or 75 cutoff. But what do you do if the cutoff is 78? The state is going to not qualify you because these are gatekeeping scores. So it's really important to have that assessment done later on when a child is getting ready to exit high school, so that you can really get a measure of their ability. And some of these agencies will ask to actually do the IQ test themselves. They want scores that are recent. The disability must have started before age 18, and that's not an issue typically with 22q because, this is an issue that's been in, since birth. The autism spectrum disorder, I'm not going to spend a lot of time on this slide because Dr. Antshel is here to be very thorough in how he diagnoses this, so he's an expert in this area. But I have included this slide just to talk a little bit about some of the areas that would be looked at in that type of an evaluation. But I am going to leave that really to Dr. Antshel to go into in more detail in just a few minutes. So the third area, which some states include, but other states do not, is the area of developmental disability, which 22q really falls into that category. It is a group of conditions that involve impairments in physical, learning, language, and behavioral areas. This is something that begins in the developmental period, which is true with 22q, and it may impact day-to-day functioning and last throughout a lifetime. When you're applying for these adult services in a state that has that third category, that's a plus, but not all states have them. So, the issue is with 22q to convince whoever is the gatekeeper of these long-term care programs to take everything into account when they're determining a young adult's need for services, including all of the physical issues, the health issues, the cognitive, the learning, and the mental health issues, because this really pulls together what these young adults are struggling with. And I think if things are looked at with just a cognitive score as the gatekeeper, this is really doing a disservice to our community. So I think, quite honestly, and I'm going to throw this out there with the hope that our community really can come together and try to do some lobbying and changing with this issue of eligibility for adult services. I've been involved with enough families that have been turned down by their states that I feel that this is really a need for our community to get 22Q recognized by legislatures around the country, so that it's not such a strange thing when a young adult comes with this diagnosis. So I think it's really important, and I think it's really a discussion that we can have as a community at a later point. But I wanted in this webinar at least to alert you to this as a problem. We have to really unite to educate the legislatures of what is involved with the syndrome and how young adults are impacted. And I think it has to be looked at as a legitimate pathway to qualifying for adult services. Quite frankly, many adults with this, with autism spectrum disorder and not 22Q, are qualifying for services, and 22Q youngsters are not. So you can have autism spectrum disorder and an IQ of 130 and get state services. And young adults with this syndrome with much more difficulty with learning and cognition are being turned down. So what can you do? I think that there are many things really we should be doing as a community. First of all, if you know a researcher in your local community that is interested in 22Q, I would encourage them to do more adult studies so we can get more information on adult long-term outcomes. We have a few studies that we rely on, but really now there's a lot more that's needed. I think it's extremely important that your child is assessed by at age 17 to see where their levels of functioning are before exiting high school. And then make sure that your doctors and school personnel really understand your child's care needs and that they document issues accurately. You don't want to paint a picture of a child that can do a lot more than they can, especially at this level of that juncture when you're going to be looking for long-term support. Once your child exits middle school, I would contact your state developmental disabilities program and try to figure out what the criteria is for your individual state to get into these long-term care programs so that you know what you're up against and can prepare the correct documentation, get the correct testing, understand really your child's needs. And I think I really want to emphasize, do not minimize this. And Dr. Antshel has some information for you, that really critical information that he is going to share with you regarding how you respond to some of these checklists that you're given. Okay, so this last slide is just letting you know that the 22Q Family Foundation is available to help you. We want to know what your story is and what's happening with your young adult. We'd like to start collecting this data so we can bolster our contention, really, which we believe that these adult services are needed and legitimately used, and that young adults need this help. If you need help with the long-term care programs, applying for benefits, understanding what you need, this is a service that we run through the 22Q Education Station. So please go through our website and apply for services. We would be happy to help you and guide you through the process. And it is best to do this no later than junior year in high school. So that is my part of this presentation. And so I will let this Lindsay take over, and I'm anxious to hear from Dr. Antshel.
Well, thank you so much, Donna, for all of that wonderful information as always. I think it's important to kind of plan earlier than later for things when it comes to this. Dr. Antshel, I think just due to time and my technology fails already, if you don't mind, I can share my screen again with your presentation. Does that work?
Sure, that's fine. And so while we're waiting on this, I'd like to thank Lindsay for the invitation to participate. And I'd also like to make sure that everybody on this call or on this webinar knows how lucky you are to have Donna Cutler-Landsman on your team. I do a lot of foundation work and a lot of work with nonprofits, and I work with a variety of educational consultants, and I am yet to come across one that's better than Donna. And so again, I really, I'm sure you're already appreciative, but I can tell you that Donna's the best. All right, and so I'm sharing screen, I see it now, and so you're going to be in control of advancing, and so.
Oh, yeah, just let me know.
Yeah, all right, and I'm trying to start my video and it's saying no, so I guess I'll just talk. I'll be the voice in the dark here. So go ahead and advance when you're ready.
Okay.
Thank you. All right, so I thought to complement the great information from Donna, I will get real quickly into autism, just because this is Autism Awareness Month. I suspect that's the main theme of today's educational activity. And so I'm going to be talking about how us psychologists or mental health clinicians, psychiatrists, social workers, et cetera, make a diagnosis of autism. And so we use a criteria called the DSM, which stands for the Diagnostic and Statistical Manual, and we're currently in the 5th edition. And there are a total of 5 criteria that have to be met. Okay, you can advance. So criteria A is the social communication. And you'll see that to satisfy the criteria here for social communication deficits, you have to have all 3 of the following. You have to have deficits in social emotional reciprocity. And so these are kids that have difficulty maintaining conversations. The conversations tend to be one-sided. They have difficulty understanding the emotions behind someone else's speech. And they have deficits in initiating and responding to others. You also have to have deficits in nonverbal communicative behaviors. And so these are things like atypical eye contact, a failure to use hand gestures. And so, for example, when we talk, we often will move our hands as a point of emphasis. Kids with autism don't do this. And then the third one is deficits in developing and maintaining relationships that are appropriate to the developmental level. And so an 8-year-old has friends with other 8-year-olds, as opposed to an 8-year-old has friends with only 4-year-olds. And so the deficits in maintaining relationships and also developing relationships. And again, for criteria A, you have to have all 3 of these. Okay, now in my experience, working with children with 22Q, they quite often can have all 3 of these. That it isn't uncommon for a parent to report that my kid is quiet and shy and really doesn't like to initiate conversation. My kid doesn't give great eye contact. And also my kid tends to befriend children that are younger. And so again, this is 20% of the autism diagnosis is that you have to have deficits in social communication. Okay, so next slide, please. So criteria B is where we start to lose some children with 22Q. In other words, for criteria A, I'd say in my experience, between 80 to 90% of parents will say, yep, my kid has all 3 of those. In criterion B, we tend to lose some parents here. Okay, so advance, please. Right, and so you'll see for criteria B, you don't have to have all of the above like we did for criteria A. You have to have 2 of these 4. Okay, and so what do all of these 4 have? They're all restrictive and repetitive behaviors. And so the first is stereotyped or repetitive speech. Okay, so the kid who has to say the same thing over and over again, the kid who comes up with new words. So for example, I'll never forget a number of years ago, I had a kid that called triangles a mashuta. And I don't even know how you spell mashuta, but that's what he called triangles. That's an example of stereotype speech. And so use of objects, so lining up things in a particular way, that's an example of that. Okay, so the next one's excessive adherence to routines. The kids that are quite rigid. So you have to have the same thing for dinner. You have to take the same route to school. If you change up something about the morning routine, it really throws the kid off. Okay, the third one is highly restricted fixated interests. that are either abnormal in their intensity or abnormal in their focus. And so abnormal in their intensity, this is a kid who collects a tremendous amount of information about Pokemon cards, or collects a tremendous amount of information about the flags of the world. I will never forget a kid many years ago who wanted to talk with me about the flag of Chile. He could have shown me just about anything and I would have believed him, but he was really fixated on national flags and how the flag from Chile was the most interesting one. And so that's an interest that's abnormal in its intensity. An interest in abnormal in its focus are the kids who are very interested in acquiring information about, let's say, street signs, or a kid who's interested in acquiring information about toilet seats or toilet makes and models. And so these are really restricted that are abnormal in their focus. And then the fourth one, which is where I have seen a lot of parents of children with 22Q say, yep, my kid has that, is this last one. Hyper or hyporeactivity to sensory input. Okay, so hyperreactivity is the kid who says things are too loud, too bright, it tastes too spicy. I can remember my kids saying that at an earlier age. Hyporeactivity is the kid who craves that type of sensory input. And so the kid who walks around feeling things, the kid who walks around sniffing things. I had a child a number of years ago in my office was attempting to lick everything. This was before COVID, but this was the kid who really had hyporeactivity to sensory stimuli and was really craving lots of sensory input. And so in my experience, the children with 22Q have those sensory, but those other three are less common, but they for sure occur. Criteria C is that these symptoms have to be present in early childhood. In my experience, 100% of parents with 22Q say, I knew something was up developmentally before my kid was in kindergarten. So in my experience, 100% will meet criteria C. Okay, next slide, please. Criteria D is that the symptoms in A and B have to impair functioning. Okay, again, as has already been alluded to by Donna, in my experience, these kids often have difficulty in functioning, particularly as they continue to develop and get into adolescence and early adulthood, where the demands for functional independence are much higher. The symptoms together have to impair your functioning. Okay, next slide. Criteria E is the exclusionary criteria. Advance, please. And you'll see here that all the stuff in A, B, C, and D cannot be better explained by an intellectual disability. Advance, please. Or if there is an intellectual disability, the intellectual disability can't totally explain the symptoms. In other words, the social communication level should be below what we expect for that individual's developmental level. Okay? And so just to make it easy, because my math is not good, that we have a 16-year-old that has an IQ of 75. So we would think that the chronological age is 16. The mental age is roughly 75% of that, which is 12. And so for a child with autism who would meet criteria, we would want the social communication level to be well below what we would expect for a 12-year-old. Okay, so next slide, please. And so this gives you some idea of how the diagnosis is made. You have to have all 5 of those criteria. Okay, and so this also gives you an idea of how autism spectrum disorder is related to other things that we often talk about in 22Q, including ADHD, social anxiety, OCD, intellectual disabilities, and language disorder. Okay, you'll see that a number of those have intersections with each of the autism components. Okay, the social impairment, the communication impairments, and the restricted interest, but you'll see the overlaps only between the 3 are in autism spectrum. Okay, so next slide, please. Okay, so here's a slide that I think does a nice job of describing the difference between autism and something that probably everyone on this call or anyone that has a child with 22Q is able to relate to, which is a language disorder or a speech delay. And so in autism, we see reduced eye contact. In speech language disorders, we see normal eye contact, okay? We don't see changes in eye contact. In autism, the child often doesn't respond when their own name is called. In a speech language disorder, that would be highly unlikely, uncommon. In autism, we don't see a lot of imitation, either action, sounds, expressions. In a speech language disorder, we do see imitations of action, sounds, and expressions. In autism, we see reduced use of gestures and facial expressions. In a speech language disorder, we don't see those kind of problems. And in fact, usually the kids are quite expressive. In autism, the kid will rarely point, that they don't really have interest in involving others and things that they enjoy. So they won't point to objects of interest. In speech language, we don't see that. Okay, and so we do see kids point to things and try to include other people. In autism, there's an unusual pattern of language development. Okay, they may say more than they actually understand. In other words, they just repeat or parrot words. They don't really have an idea of the comprehension of those words, but they repeat it. In speech language disorder, we see the opposite, okay, that the kid usually understands much more than they can say. And then the last one, in autism, kids with autism do not engage in pretend play. In speech language disorders, we do see a lot of pretend play, and they're able to use their imagination. Okay, so next slide, please. All right, so how do we make an autism diagnosis? There are three main components. Okay, the first is an interview with the parent or the caregiver. Right? And so this is the one you'll see is kind of the gold standard in the field. It's called the ADIR. And when you apply for Social Security disability or you're aging into adulthood, usually those agencies are going to want to see that an ADIR was involved in the autism diagnosis. Okay, and so this was an interview. It lasts anywhere from an hour and a half to 2 hours. And it's a lot of questions about those criteria in A, B, C, D, and E that I was just asking you about. Okay, so next slide. ADOS2, the ADOS2 actually involves the child. Okay, so the ADI or the ADIR involves the parent. The ADOS2 stands for Autism Diagnostic Observation Schedule, and that keyword there is observation. Okay, that it's an interactive series of games and puzzles and other things in which the examiner is observing how the child is responding. Okay, so let me give you an example of something that's in the ADIR. I might say something like, on my way to work, something really surprising happened. Okay, and then I would stop. Okay, and then I'm looking for the child who I'm doing the ADIR, and in this case, an elementary school kid. I am looking for the elementary school kid to express interest in understanding what was surprising. Children with autism will continue to be kind of in their own aloof world and really won't have an interest in understanding what's surprising on the way to work. And actually, if you want to know what is surprising on the way to work, I saw a clown skipping on the side of the road. That's what I say. And usually the kids have great interest in wanting to talk about it. And usually I say, I don't think this is autism. All right. So again, I, as the trained examiner, am looking to see how the children are responding to a series of prompts and other puzzles and games and activities. And children with autism respond really quite differently. Okay, so next slide, please. All right, so here is the third component of that autism diagnosis. It is the Vineland, and it is called the Vineland Adaptive Behavioral Scales. All right, so VABS, we're currently in the 3rd edition. This is a questionnaire, or it can also be a survey interview that is given to the parent. All right, but again, this goes back to the parent. The ADOS is the only part that involves the child. The ADIR and the Vineland are with the parent. Okay, and you can advance, please. And so in the Vineland, you as a parent are asked to use a 0, 1, 2 scale. Right? And so a 0, 1, 2, and I really want to spend some time here helping to walk you through this. A 0 means your child is never able to perform it or is never able to do it without help or without prompting. Okay, so for example, if you say my child will never brush their teeth unless I prompt them, that's a 0. Okay, a 1 is when the behavior is needed or appropriate, the individual sometimes will perform it without help or without prompting. Okay, and so again, going back to the toothbrush, if you say, well, my kid will do it probably 2 or 3 days a week, they'll do it on their own. The other 3 or 4 days of the week, I have to prompt them to brush their teeth. That's a 1. A 2 is when the behavior is needed or appropriate, the individual usually performs it without help or without prompting. Okay, and so you can advance, please. Okay, and so I think what is critical here to I should go back because I really want to highlight the does, not can. A 2 on the Vineland mean your kid does it, not can your kid do it. Does your kid do it? All right, and so we really want to emphasize, and I'm sure that Donna will resonate with this. When you complete the Vineland, you want to think about your child and their typical behavior, not them at their best, because that's not what the Vineland is about. The Vineland is about their adaptive behavior, and adaptive behavior is the everyday deployment of independence. Okay, and so a 2 means the kid does it, not can they do it, do they do it? Okay, and so those 3 things are used to make an autism diagnosis. All right, so now you can advance the next slide, Lindsay. Sorry for jumping quickly on you. All right, and so I'm happy to answer any questions, and I'm sure I can also say that for Donna. I'm happy to answer any questions about autism or anything that I've discussed. And so again, I really appreciate the opportunity to talk tonight with the foundation and also to co-present with Donna.
Well, thank you so much, Dr. Antshel. That was really informative. I think there is such a fine line between some of the overlap with some of these behaviors that we see with our kids. But when you break it down like that, it is, I feel it clearly states, if they do have autism or not. However, the issue that you just brought up at the very end, like does versus can, because I think a lot of times us as parents, we want to, hope for the best, assume the best, but that's not necessarily helpful when it comes to getting the services that these kids need, based on how you're answering it. So I'm going to open it up for questions. If anyone has any questions, feel free to put them in the chat. And I do apologize for all of the technical difficulties today. It's been a little rough, but I appreciate you guys hanging in with us. If you have questions, you can comment them, put them in the chat, or raise, the Q&A, and I can make sure to pass that along. Donna, did you have anything to kind of say in regards to Dr. Antshel's presentation?
I'm so thrilled that Dr. Antshel shared that information. I think it's so important that families really understand how these diagnoses are made and what the criteria are. I find oftentimes, for example, with the Vineland, that that tool is used a lot, but I don't think it's answered in the way that it's supposed to be answered. And I loved that piece of information, that it's actually doing it independently. Do they completely do it independent, or can they do it but need to be prompted to do it and need to be helped to do it? There's a real difference in that. I find sometimes with the Vineland that parents will score their child very differently than the staff in school will score them. And yet the staff will say, well, they're getting para support, or they're getting all the support, and they'll come up with average or above average on the Vineland. And I can't understand those answers, because, if they're getting all this help, they're certainly not being independent. So I think that this discussion was really helpful. I'm hoping that we can do a lot more with supporting families as a community with securing these long-term care services. The Vineland is used for an intellectual disability diagnosis as well, so that instrument is really important to understand. But the other areas are with the autism diagnosis and the intellectual disability. There's been a number of adults with 22q that have not been awarded services because their IQs are slightly higher than the cutoff and they don't meet all the autism criteria for a diagnosis of autism. So it's a very difficult situation that I think we need to work together to change.
I couldn't agree more. Yeah, I think it's, you know, a lot of the adults that we're seeing in our community, just those adaptive skills are fairly weak. And so just being able to properly identify like what the issues are, so that hopefully, you know, hopefully as we bring more awareness about 22q, I think that's, you know, a lot of the issue we talk a lot about at the foundation is, you know, talking about autism, talking about 22q, and you go out into the world and say that your child has 22q. It's just a constant kind of fight to get the services that you need, because obviously it is a spectrum, just like autism is. But because of just the unknownness sometimes too, it's just such a battle to get the services that our families need. We have one person that commented, thank you so much for clarifying the can do, because it's helped me very much for this to reflect on my child's competence. So yeah, I think that is that's my biggest takeaway, I think, of this conversation. And it's hard. I mean, I think it's hard to be honest about what your, you know, kids can do and can't, because you want the best for them. I think we have a question. So give me 1 second, Deborah.
Yeah, sorry with you, Lindsay. I'll jump in. I mean, I think that's important. I'm a parent too. And so I want to think about my child in the most positive light. I also want to help my child be as independent as they can as an adult. And I think over-representing what they can and can't do, I don't know that that's the best thing for a child. Again, I absolutely understand, and I find this a lot with teachers. And so for sure what Donna said, it resonates with me, that the teachers, I think, are really wanting to be as positive as possible. And so they say, yeah, this kid does this, or this kid can do this. But again, I can tell you, the agencies that are making these determinations, I'm sure they want to support everybody they can, but they are under financial constraints. And so they really have to give it to the most impaired people. And if we are rating our child in a more aspirational way, or we're rating them as opposed to what they can perform rather than do perform, again, I can tell you the experience is for sure consistent with Donna, that a lot of times the states are saying, well, these kids don't need these help. Mm-hmm. These adults are independent by these scales, and yet you talk to the parent and they say, oh, no. My child can't cook or can't clean. They're not able to do their own bank account. They can't drive, whatever it might be. So I get it, but I also encourage us really to think about our child's, you know, what's in their best interest, and as opposed to what's going to make us feel good about ourselves as a parent. Because I've done these rating scales too, and I like to say, yeah, my kid can do that.
Of course, right? Deborah, you have your hand up. Go ahead.
Yeah, thanks. I guess I'm not video, but so here's my question. Our son went to do several different research studies on 22q when he was younger. And one of those was at UCLA. And at UCLA, they did some sort of screening on him. I don't have the paperwork in front of me for a whole host of things. He was there for 2 days or whatever. But one of the things they did was they gave him an autism diagnosis in the 22q clinic. And I have not asked for the school district to put the AU label on him, because we've gotten what we needed with an OHI label. And I've always discounted the UCLA finding, because to me, that's not predominantly what it is. It's really 22q. But now I received something about some training and services that the Autism Society or whoever locally is putting on. And I realized, wow, that would be good. They have an employee assistance program with coaching. which I suspect is a supplement and better than what the state of Texas does. And then they've also got some other like mentoring programs and things. And I reached out and I said, hey, you know, I see you've got this stuff and you've got a social skills group for 18 plus kids. My son has this label, although I don't know that that's really the right label. And they said, well, we can count that label. Here's the real, so that's just a background. My question is, now that my son is close to turning 18 and he's still got another year of high school, but two things I guess would be about, is there any reason to get an AU label out of the school district? More importantly though, shouldn't those of us who are in this boat, who are able to get an autism diagnosis, just use that now for everything we can until with Donna we change? It seems to me like we ought to use the Biden administration as an opportunity to get the federal government to issue guidance to the state agencies around 22Q, that would be more efficient than trying to lobby 50 state legislatures. But either way, like is that what we should do? Lean in on the 22Q label? Is there a reason we can't? Is there harm from doing that? And, you know, until we get it to where they'll recognize us for, you know, the label we do have that we think is probably better and more appropriate.
To be honest with you, I would put both labels. I would put a dual diagnosis of autism and 22Q, because they will look at both. And I think they know autism. These state agencies know autism. They don't really understand 22Q. I mean, there are a lot of genetic issues of genetic deletion syndromes, and, you know, many adults have a diagnosis of some type of syndrome, and they're not impaired to the level of needing long-term care. So in my opinion, and Dr. Antshel may disagree, I don't know, but I would put both down. I would be as clear and as inclusive of the needs as possible on these applications, because I don't think it's going to hurt you to have that diagnosis. And I would contact really the school system and have that included in the IEP, so it's documented through the school district as well. As well as the district being very clear about what the needs are, and how much help he's getting and what sort of services the school district is providing as well.
And do I have a problem with that assessment? And it's a nice report from UCLA. I mean, that sounds good. But it's from, you know, 10 years ago or whatever.
No, I'm actually, the earlier the diagnosis for autism, the more reliable it is. And so I can tell you that the state agencies quite often look at a diagnosis that isn't made till age 14 or 15 with great skepticism. And so the diagnoses that are made from childhood are actually more robust, and they tend to be viewed in a different way. Now, again, that doesn't mean, again, I want to be clear, I have never met your son. I don't know if he has autism or not. All right. And so please don't walk away thinking.
No worries. No worries there. I've been saying he doesn't forever. So I'm the worst problem so far.
Yeah. Yeah. But to answer your question, no, actually the datedness of that evaluation for this diagnosis, and the reason is, if you go back to criterion C, that there has to be evidence in early childhood. The earlier the diagnosis, the more the state agencies trust it.
Thank you very much.
Thank you for that question, Deborah. That was great. Just looking to double check. I don't see any other questions. So I guess we could just, oh wait, oh, there's one. All right, so CC asked, if we wanted our child to be evaluated for development, i.e. autism, what type of specialist should we go to? Neurologist, psychologist, neurodevelopmentalist? She said her child is 13 and finding his emotions and actions are a bit changing. He's starting to be more anxious to be in public, don't want to look at people in the eye, and which was never the case before. He wants to wear sunglasses when we're out in public now. What can I do to get him back to being okay with strangers, and out in the public, he tries to avoid eye contact?
Sure, yeah, so I can handle this one, Donna. So yeah, and so the question about what type of specialist. I think what type of specialist is less important than what test is that specialist going to use. And so I would be looking for the ADIR and the ADOS, okay, because that's the gold standard, and that's what these agencies are going to want to see when you are applying for paperwork. And so as opposed to saying, who should I go to? I would ask, what are the tests that these folks are using? And quite often it's on websites, etc. Usually the psychologists and the developmental pediatricians, those two groups are more likely to do this because those two groups are more focused on assessment. But I would be less concerned about who does it and more concerned about what they use to do it. With regard to what you're describing, these sounds like changes in adolescence. And what we know about social anxiety disorder is that it begins to have its increase in onset and prevalence in roughly in middle school. So age 11, 12 is usually when the kids start becoming more self-conscious, more aware that other people have opinions about them. And so if these are changes that you're describing, those changes to me sound less like autism and more like social anxiety disorder. The treatment for social anxiety disorder is exposure, right? And so the more you allow people to avoid things that make them anxious, the more anxious they get about it. And so we have a whole cadre of children with social anxiety disorder that have been completely physically and socially distant in COVID. And there's a lot of people, including myself, in the mental health field that wonder, how is this reintegration going to go now that all these socially anxious kids who have been a void, and I hear a lot of reduction in anxiety through COVID, are now going back to school. And so the exposure, even though it makes them more anxious, is really the treatment. But I would encourage you to get with the mental health professional in that community that you live in, because as a parent, it's very hard to do exposure because often parents think this is being cruel and inhumane, that I'm telling him he can't wear his sunglasses or he can't do other things. But exposure is really the best treatment for social anxiety.
Thank you. Yeah, I feel I feel that mom for sure, because my 7-year-old just went back to school today for the first time. I think today was deer in headlights day, though, is what I like to call it. For the first day back, you did great. We'll see how tomorrow goes. But yeah, a lot of these kids have been really thriving. A lot of our 22Q kids have been thriving at home, because besides, of course, looking at the screen with the 30 faces, you know, staring at you. Yeah. Let me see if there's any last questions. She's just said, thank you. Well, this was really informative and really helpful. I think it really just shows the differences of, you know, 22Q autism, what you need to do in order to get an autism diagnosis, and how this is going to affect, you know, long-term needs. One more question that just popped in. Is there any information on the success rate on the Vineland of children with 22Q who have more normal IQ?
I guess I would want to know how we're defining success. I mean, are you defining people on the Vineland are successful if they come out as being in the average range? If that's the question, I would say even in my experience with 22Q, even those kids who have average IQ, there often are adaptive behavior deficits. And so that they're, yeah, let's just say for the sake of simplicity, their IQ is 100, but their scores on the Vineland are 85. In other words, it isn't quite what we would predict given their intelligence. And there usually are strong correlations between the Vineland and IQ. Again, it's a measure of functional independence. And so if you're defining success on the Vineland as being an average, as being average scores on the Vineland, I would say, and again, I defer to Dawn on this because she probably has seen more Vinelands than I have, but I've seen a couple hundred of 22Q. And even for those high achieving kids who have an average IQ, the parents are reporting that the kid needs to be prompted and reminded to do activities of daily living.
And I would confirm that that's what I see. I see it, you know, oftentimes parents are feeling that their children really are not independent, that they have to be prompted through tasks in order to complete them. Now, if they're coached and taught a skill and it's demonstrated, modeled, and they've practiced that skill multiple times, they can become independent at it. You know, and I will say that as these young adults mature through life, my experience has been that they do get some of these skills over time by being exposed and having to do them, going to work, for example, doing those kinds of things over and over in a defined world. But when you get out of that defined world where there's a problem to solve and it's not typical and they're not used to that, that's where the deficit kind of becomes more obvious. And again, somebody needs to kind of hop in and give that young adult assistance. So that's more the negative impact, I think, of the syndrome, and would be showing up on the Vineland, especially if it's answered as Dr. Antshel suggested it should be answered. And, you know, you're really looking for independence really on the first shot at a task. Can they figure it out, problem solve, do it, and not have to be coached through it in order to complete it?
Thank you to you both for that detailed answer. All right, well, I don't believe there are any more questions. I want to value both of our presenters' time since they are on the East Coast and it's getting late. Thank you everyone for being part of this. We did record it as well so that we can show it to many more on our YouTube channel. And again, I apologize for the technical difficulties. Thank you so much, Dr. Antshel, for being with us, and Donna for being with us as well.
Sure.
It was my pleasure. Thanks, Lindsay.
Have a great evening, everybody.
Right.
Thank you.
Sounds
Bye,
good.
everyone.
Bye.
Take care.
Thank you.